My name is Dr. Richards. I'm talking to you today about bariatric surgery or weight loss surgery. And I formatted this talk about what we give to our potential patients. In other words, is it right for you? Just talking about some of the options in bariatric surgery. We're going to talk a little bit about why it works and a whole bunch of things. So let me get started here. So what are you going to learn today? We're going to learn what is obesity. We're going to talk about what are the consequences of morbid obesity. What are the surgical options available for treatment of morbid obesity? And what are the next steps at USA? So what is obesity? Obesity is a disease of excess fat storage, with a number of associated diseases known as comorbidities. It is caused by many factors: environment, hormonal, genetic, and we're going to talk a lot about a lot of the biology of why things occur. It is lifelong, it is progressive, and it is life-threatening. A lot of people think they're really morbidly obese but generally healthy. If we really look into that morbid obesity, we find that there are a lot of comorbidities that you don't know about that are harming your life. Consequences of obesity. Obesity is associated with these comorbidities. Type 2 diabetes. So type 1 diabetes is younger kids, usually called juvenile onset diabetes, in which the pancreas doesn't secrete enough insulin. In type 2 diabetes, it's because of the obesity, patients develop insulin resistance. That means that the insulin your body makes doesn't work to bring down the blood sugar. And that failure to bring down the blood sugar makes your blood sugar go up, okay, and then you develop diabetes. High lipid levels, high cholesterol, and other lipids that clog up the arteries. High blood pressure or hypertension. Obstructive sleep apnea is a disease in which patients stop breathing at night, okay, usually an obstruction in the upper airway from the soft tissues of the oral pharynx. You stop breathing, your blood oxygen goes down, and then you have a fatal heart attack. I've had I know of 2 patients that were scheduled for surgery that died of obstructive sleep apnea. So obstructive sleep apnea can be a very deadly disease in which your blood oxygen goes down and then patients have strokes or heart attacks or other types of problems. It also affects your everyday life because patients don't sleep well at night, and therefore they fall asleep in the afternoon, even while driving. So we've seen a number of accidents caused by unrecognized obstructive sleep apnea. Heart disease, stroke, asthma. You wouldn't think that asthma is related to obesity, but morbid obesity, and particularly central obesity, causes an increase in these chemicals called cytokines. These cytokines cause inflammation, okay? So that people who are morbidly obese will oftentimes have much more difficult to control asthma or new onset asthma because these inflammatory chemicals go around and inflame the lung. So you have increased levels of asthma. Osteoarthritis. So particularly of the hips, knees, ankles, plantar fasciitis. But these inflammatory cytokines are also going around destroying your joints. Okay? So the morbidly obese person has a lot more inflammatory chemicals in their bloodstream that cause much more inflammation and destruction of the joints. So you actually do have more pain and discomfort because it's biology. It's biology. It's not in your head. Depression and Obesity is known to be associated with increased risk for cancer. What are the cancers that we're particularly concerned about? Colon cancer, ovarian cancer, breast cancer are probably the big three. Okay? And many other cancers are known to be associated with obesity and increased risk. So, metabolic syndrome X. I love that title. It's an evil disease. It's probably our number one, quote-unquote, chronic disease here in the United States, and it's a worldwide epidemic of metabolic syndrome X. Metabolic syndrome X was first coined among Asians over on the West Coast. So these researchers identified these people that weren't really big, but they had central obesity. They had high blood pressure, hypertension. They had abnormal lipids in their bloodstream. They had diabetes or prediabetes, impaired glucose tolerance, or insulin resistance. And this triad means that you're at high risk for developing cardiovascular death. Okay, how do we measure obesity? We measure it by body mass index. So does everyone here know their body mass index? I should have brought, Valerie, do we have any of our cards out here? I guess we don't. We can, if you don't know your body mass index, we can quickly calculate it. Valerie over there is our bariatric manager. She does everything. In fact, she saved my talk today because I went to get my hard drive. I pulled out my trusty hard drive that I've had for 4 years, had all the talks on it, and lo and behold, fatal error, not working. So I quickly called Valerie, and she had an extra hard drive. Okay, so acceptable range, 18 to 25. Overweight, 25 to 29. I'm in this range right here, edging up to this range. Obese, 30 to 35. Severe obesity, 35 to 40. Morbid obesity is designated as a BMI between 40 and 50. Supermorbid obesity is greater than 50. The highest BMI I've ever seen is 103. I've seen about 5 patients whose waist circumference exceeded their height. Okay? It's not unusual for us to see patients with BMIs in the 80s and 90s. And as you can imagine, that level of obesity affects many, many things. So treating obesity, particularly morbid obesity, is it really about the fashion statement, or is it about truly treating the medical condition? And I'm going to tell you that we're really trying to treat the medical conditions. And once we see patients in clinic, we oftentimes identify several more diseases or comorbidities that they have before surgery. Okay, so how did we get into this situation? Okay, is it Ronald McDonald? Well, yes, it is. Apparently, it's also the USA Food Service who did not deliver any of the water and did not deliver fruit for dessert, but decided to give us the high-calorie, high-fat, high-sugar cookies and sodas, okay, with a high-fructose corn syrup. So really, it's all about USA is causing it. But Ronald McDonald does have a lot to do with it, because nowadays you can drive through, get 5,000 calories for what? $5. Okay? And the calories that you get there are oftentimes high in fat and high in sugar. Okay, so the Centers for Disease Control, federal government, started to look back here in the 80s, what percentage of patients had a BMI greater than 30 in each state. Okay, so BMI greater than 30 means obesity-related problems. And you can see here in 1990, Mississippi is leading the country as it has every year since. Alabama is usually number 2. Tennessee was number 4 back in 2009 when I moved. They've since gone, when I moved from Tennessee to Alabama, Tennessee went from 4 to number 5. I think that's because I moved. And Alabama has stayed number 2, except we're number 1. We're number 1 in the nation in terms of the percentage of our adult population that has type 2 diabetes. We lead the nation. We're higher than Mississippi. So we beat them at football. We also beat them in diabetes. We don't beat them in obesity rates. But here you can see in 2005, sort of the biscuit belt here, the South is very, very high in obesity. Here it is in 2010, greater than 30% of the population of Mississippi and Alabama are obese. So, generally speaking, the United States has an obesity problem. It is, however, a worldwide problem. So this shows the prevalence of overweight in children over time from the 1970s to about 2000. And you can see every country in the world is increasing. Some countries are increasing at faster rates, and some countries are overtaking us. Okay? Now, after you've memorized this, okay, so a lot of people think that eating is all about your brain and everything else. But notice that the brain is taking all the orders from the GI tract and from fat and from your pancreas. It's not the brain, it's the GI tract. The GI tract is driving eating behavior to a large degree. Okay? So the stomach secretes a number of peptides. We're going to concentrate looking at ghrelin. But even fat secretes leptin. So if you have leptin deficiency, you're massively obese because your body is being told to eat. Okay? It's amazing how a defect in fat producing leptin can cause this. Okay? So there are some genetically predisposed people that have leptin deficiency or other deficiencies, abnormalities in these peptides that cause massive obesity, and these people will just eat and eat and eat. That's because their brain is being bathed by these chemicals that tell them to eat and that they're not satiated. But you can see it's a very complex feedback mechanism that goes through back to the brain to the satiety and hunger centers and everything else, and goes back to stimulate insulin and other things that go on in the gut. So it's a very, very complex situation. And one of the things people tell me, well, don't you think that bariatric surgery will go by the wayside because they'll find a drug to make you stop eating? Okay, this just describes a few of the hormones that we know. We know about 40 hormones that are involved in eating behavior. Okay, so a drug knocks out one of these pathways. What do you think happens? The other pathways upregulate and cause you to eat again. Okay, so almost everyone can lose weight for about 6 months. It's the long-term weight loss and weight maintenance is the really difficult thing. And then again, we've got multitude of drugs that actually cause people to eat more. There are a lot more drugs that cause people to eat more than there are that cause people to eat less. But we're biologically hardwired to eat. One of the hormones that we're going to talk about is the hormone ghrelin. It's the so-called appetite hormone. Levels are elevated when fasting or going on a diet leading to hunger. Ghrelin is secreted by the stomach. And we're going to talk about ghrelin later. So, if nothing else, just remember ghrelin. Ghrelin, ghrelin, ghrelin. Okay? Be fascinated by it. Okay, so let's talk about surgery. Common surgical approaches, I'm going to talk about 3. Laparoscopic adjustable gastric band, laparoscopic gastric bypass, and laparoscopic sleeve gastrectomy. Notice all 3 are laparoscopically, minimally invasive, small incisions that has fundamentally changed surgery. It's not just that they're cosmetically better, it's that they fundamentally change surgery. Why? Less blood loss, less pain, less hernias, less surgical trauma, faster recuperation. That all translates to a dramatically tenfold reduction in morbidity and 4-fold reduction in mortality. So our laparoscopic operations are less morbid and less risky in terms of death rate than, say, a bilateral knee replacement. Okay? So we can divide the GI tract and do all these operations inside the abdomen at a lower risk rate, lower mortality rate than for bilateral knee replacement. Here's the lap band. I forgot to bring my lap band with me. It is implanted laparoscopically around the upper stomach. It is attached to this tubing, to this port that's buried underneath the skin. We then access it with a skinny little needle, and we can fill it up. It's the 3rd most frequently performed bariatric procedure here at USA. Excess weight loss at 1 year of about 42% requires this implanted medical device. It has a very low risk of complications. Most of the procedures that we do are done as an outpatient procedure. Outpatient. That means you come in the morning, have your surgery done, you go home later that day, or you just stay overnight, leaving the next morning. It is the least invasive, no stapling or rerouting. It is adjustable. That's why it works. It's adjustable or reversible. We can take it out. It has an extremely low mortality rate for this procedure. A small pouch is created which limits the amount of food patients eat. The smaller stomach fills quickly, helping patients feel satisfied with less food.
The lap band adjustable gastric banding system is a tool to help you achieve sustained weight loss by limiting how much you can eat, reducing your appetite, and slowing digestion. The lap band is an adjustable silicone ring that connects to an access port by thin tubing. The lap band AP system is the 3rd and latest generation lap band system. Its design and performance are the result of 7 years of U.S. experience, as well as countless collaborations with surgeons across the country. When placed around your stomach, the lap band AP system immediately provides a fit tailored to your anatomy, which allows for optimized weight loss right from the start. Omniform inflation, which provides 360 degrees of pressure evenly delivered throughout the band for complete stomach coverage. Soft and flexible pre-curved individual sections that help minimize the potential for leaks from creases or folds. The highest fill volume available, which leads to greater flexibility and customized adjustments. Available in 2 sizes to accommodate different anatomy and individual needs. The lap band system surgery is usually performed laparoscopically. The device is inserted through one of 5 or 6 small incisions and is wrapped around the upper part of the stomach. This creates a small upper stomach pouch and a narrowed outlet between the new upper pouch and lower stomach. The lap band system is connected by a tube to an access port fixed to the muscle wall just below the skin of your abdomen. Using a fine needle, saline solution can be added or removed from the band to find the right level of restriction. As saline inflates the inner surface of the lap band system, the stomach outlet becomes smaller. This helps reduce the amount of food you eat and slows the emptying of food from the upper to the lower part of the stomach. This helps you feel full sooner and stay full longer. The lap band system is the #1 adjustable gastric band sold worldwide.
Okay, so what are the risks of a lap band? Related to the device malfunction, so the implant, the band, can erode into the stomach. That's a pretty rare event, but it can occur. The band can slip out of position. That's more common over the lifetime of the patient. Probably approaches about 1 out of 10 patients might have to have a reoperation to place the band in better position. Okay? The port can be displaced, leading to a reoperation. Tubing-related complications, port disconnection, tubing kinking, band leak, port site infection, esophageal spasm, meaning that we've tightened it up too much and the esophagus dilates. It's obstructed. It's sort of like making a dam. The river builds up into a big lake. Okay? Gastroesophageal reflux disease, slower initial weight loss. So the weight loss after the lap band is very, very slow. It's about 1 to 2 pounds per week, only if you come back to visit me, because I have to add more fluid to make it tight enough so you feel that sense of satiety. If you never want to come back to see me, I don't suggest that you undergo the lap band because it just won't work. Okay? It's all about the adjustments afterwards. Regular follow-up is critical. Here's the most common operative procedure that we're doing right now, called the laparoscopic sleeve gastrectomy. Here's the stomach. Here's the duodenum here. This is the liver here. Here's the esophagus. We turn the stomach from being about the size of a football down to a long, narrow tube. And we actually cut out this part of the stomach. We actually excise it. So that's not reversible. Once we've had that done, we've removed the stomach, we can't put the stomach back. It's a rapid initial weight loss, no implanted medical device, minimal to no dumping. Dumping syndrome is something that we see primarily after gastric bypass. And that's when people eat a liquid food like a chocolate ice cream sundae that's high in sugar. It goes directly into the small intestine, causing cramps, a rapid absorption of blood glucose, a rapid absorption of glucose into the bloodstream, which causes a release of insulin. And then patients become low blood sugar because they have high insulin levels and they don't have continued ongoing infusion of glucose into their system. So dumping syndrome helps some people after gastric bypass learn not to eat sweets. Okay, that's the theory. But dumping syndrome is not fun to have. There's a low risk of malnutrition, but not zero. You still have to take vitamins. Because the stomach is intact and it's mixing with bile, most nutrients are absorbed normally.
The sleeve gastrectomy is a restrictive procedure, which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So what are the results? This was a paper that was published about 3 years ago, 5-year results, and basically they had really good 5-year results. Now ghrelin is secreted where? Stomach. So you remove 85% of the stomach, what happens to ghrelin levels? Goes down. So do you think you're hungry after a laparoscopic sleeve gastrectomy? Generally speaking, the patients will report a significant change in their appetite. They oftentimes report a significant change in the types of foods that they find appealing as well. But this reduction in ghrelin levels really makes the sleeve gastrectomy work quite well. What are the risks, complications, and disadvantages of sleeve gastrectomy? You can always have bleeding after any surgery. You can leak at the staple line. This appears to be the Achilles heel. Leaks are not common, but they're more common than we'd like to see. You can create more heartburn if you don't repair the hiatal hernia at the same time. We always look for hiatal hernias and try to repair them. It is really non-reversible, and it's not adjustable. Once we do it, we can't adjust it, and it's not reversible. Complication rate is higher than the band. It used to be that it wasn't approved by all insurance providers. In fact, there's still a few insurance providers that will not cover the sleeve gastrectomy, but most of our insurance covers do cover it at this point in time. This is the laparoscopic Roux-en-Y gastric bypass, or laparoscopic gastric bypass. We divide the stomach into 2 compartments. This one is about the size of an egg, so it's really, really small. We divide the small intestine, hook it up here, and hook this up so your food bypasses this part of the stomach and goes directly into the small intestine. It doesn't mix with bile or pancreatic enzymes until it gets down here in the common channel. So this has been the gold standard for bariatric surgery for a long, long time. Now it's being overtaken. All 3 procedures work extremely well and work to change the physiology of eating. Mean excess weight loss at 1 year of about 67%. There's a very fast weight loss that goes on for about a year and a half after surgery. Rapid resolution of many comorbidities. No implanted medical device. Low rate of complications in experienced hands.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So, why does gastric bypass work? Okay? This is ghrelin levels in two patient populations. Okay? One patient population, this is the same patients. These are about 30 patients who underwent a weight loss program. So here they are at baseline with their ghrelin levels over a 24-hour period. And what you can see is ghrelin levels in these normal individuals goes down after they eat breakfast, goes up before lunch, and then goes down after lunch, and goes up before dinner, and they eat dinner, and then it goes down. So it sort of makes a whole lot of sense. Your ghrelin levels sort of go up and down, and as you eat, they should go down, okay? Now, these same 30 patients have been on a weight loss program, and they've lost about 10% of their body weight, okay? And here they are, 6 months later, they've lost weight, and ghrelin levels at every single time point are much higher. Still goes down after breakfast, goes down after lunch, goes down after dinner. But what does that tell you about these patients that are on a diet? Patients on a diet who have lost weight feel hungry or not hungry? Yes. And the longer you diet, the more weight you lose, the more your body tells you to eat more. Because the body is sensing that you're losing weight, therefore it's a threat to your life because you're now not getting enough calories. Okay? In other words, the other way to look at it is this is sort of your thermostat. Ghrelin levels are sort of your thermostat to tell you when to eat. And your response to eating, if the ghrelin levels really fall down here and stay down, you don't eat in between, okay, because you're not hungry. At least that's the theory, okay? So let's look at ghrelin levels after gastric bypass. And lo and behold, after gastric bypass, ghrelin levels are really low. We don't know why ghrelin levels fall to such a degree after gastric bypass, but that's one of the major reasons why gastric bypass works so well. Ghrelin levels are low. Patients after gastric bypass just aren't very hungry. Okay, so let's go back here. What are the risks, complications, and disadvantages of gastric bypass? Bleeding, leaks, ulcers, stricture, or a narrowing from scarring at the anastomosis of the connection. Hernias, dumping syndrome that we've talked about. You need to take a good diet with daily multivitamins and minerals because you've bypassed part of the absorptive capacity of the GI tract, so you're prone to develop vitamin deficiencies. And you have to take vitamins, otherwise you will develop a serious vitamin deficiency. Since we've bypassed the stomach, there are parts of the stomach, duodenum, and parts of the intestine that are hard to access. At least they were hard to access 20 years ago. Now we have a lot of techniques that we can access them. May require a little bit extra things to do, but we can access those parts of the GI tract. Risk of any abdominal surgery, bleeding, pain, pneumonia, complications due to anesthesia and medications. You can develop clots in the legs, or those clots in the legs can break off and travel to the lungs killing you. Injury to the stomach, esophagus, or surrounding organs like the spleen, infections, hernias, bowel obstruction, and death can occur after any abdominal surgery. So let's talk a little bit about some of the results, and these are some of the results that I have published and looked at in my own patients. So this was a study that we did about 3 years ago. 71 to 74% of diabetic patients had complete resolution. The internists, the diabetologists, really don't like us to talk about curing these patients, but we can say that they had complete resolution. That means they didn't take any medications, they didn't receive any insulin, no pills, no other treatment. Their diabetes went away. In other words, we have a surgical treatment for type 2 diabetes that is much more effective than any medical treatment because it completely goes away. Okay? And was improved in 94% of the patients. Okay? The 6% of patients that it wasn't improved in are usually patients in which the patients have had such long-standing diabetes that their pancreas is so burned out that they're not making insulin anymore, and they're beyond hope. My theory would be that if we were able to do surgery earlier in their life, that they would have been better off and their diabetes would have been resolved. What about cardiovascular risk? Because this metabolic syndrome X is a marker. It's a disease that causes hardening of the arteries, heart attack, and stroke. And you're manyfold more times likely to die of stroke and heart attack if you have metabolic syndrome X. And we looked at that in our gastric bypass patients, and we showed that there were significant 2 to 3 times decreases in the prevalence of cardiovascular risk factors, including hypertension, diabetes, and dyslipidemia in these patients undergoing gastric bypass. Okay, what has my experience been? I've done more than 1,300 laparoscopic bariatric procedures. I've had 7 leaks after gastric bypass or sleeve. All these patients required an operation to fix. That's about a half a percentile. None of these patients died. Okay? We've had 4 patients that had blood clots in the legs, and we had to treat those patients. No operative deaths, meaning within 30 days of surgery. I know of some of my patients that have died subsequently. I've been doing this for about almost 13 years, so patients have heart attacks, or they have cancer, or they have other types of things that happen to them, and obviously some patients, we all end up dying at some point in time in our lives. But I've had no operative deaths during my entire laparoscopic bariatric career. So bariatric surgery has now evolved into a team effort. So I need a lot of people on the team. Here's Valerie, right back there in the back, okay, and she can calculate your BMI if you don't know that. We have dietitians that work with us. We have a research nurse. We have our nurses in the clinic. Here's our nurse practitioner. How to maintain or achieve weight loss. Begin making the changes today. Cut back on high-calorie beverages. Avoid fast food. Make healthier selections. Try to get protein first. Portion control. Slow down while eating. So it takes the brain about 20 minutes to figure out that you're full. So you can fool your brain by eating really, really fast, and you can double up, triple up your portions. How many of you watch Man vs. Food? You don't have enough teenage boys. Listen, you ought to watch that show one time. Man vs. Food. It's really amazing how much these people eat. But the key to it, to eating a lot, is eat really fast before you hit that 20 minutes. After about 20 minutes, your brain actually figures out that you're full. Okay? So there was one time I was watching it just recently last week with my son, who was showing my parents, his grandparents, all about man versus food. I mean, this is what teenage kids do. They show their grandparents the really sick TV shows. And, you know, the guy was doing this challenge. 5 quarter-pound hot dogs, 4 pounds of chili, ground beef chili, 2 pounds of melted cheese, and 2 pounds of French fries. Okay? And this challenge, there had been like 35 people that had tried to eat this. Only one person had ever eaten this massive hot dog combination. He ate it in 17 minutes, okay, before his brain had an idea that he was full, okay? So if you want to lose weight, eat your meal in about 25 minutes. After 30 minutes, you don't want to eat anymore, but you want to slow down so your brain has a chance to catch up and figure out that you're full. Portion control, slow down while eating. Do not drink water with meals. So the reason you don't want to drink water with the meals is because you then turn the solids into a semi-liquid. It empties quicker. Okay? So eat the solids and don't drink. No snacking. We put in here stop smoking, but that's because we want people to do a healthier lifestyle. Exercise is very important. So men have an inherent advantage over women. That's because we have much more muscle mass. So we can eat more. We can drink more. We can just do more because as a percentage of our body, we have more muscle mass. But women need to also exercise, and it's not just aerobic exercise that we recommend, but weight training so you develop muscles, and the muscles burn calories even at rest. So that's important too. Okay, we do a pre-op meal plan. We do a full liquid, high-protein liquid diet 5 days prior to surgery. Goal is to reduce the liver because many times the liver in these patients is very, very big. It's chock full of fat. And the first place the body goes to when you're on a diet is to reduce the size of the liver by basically metabolizing those fats for energy. Okay, so we find it's very effective. I can do the surgery faster, better, and everything else. And we do those types of things. Here's what they do post-operatively. You don't eat anything or drink anything on the day of operation. By day 3, you're tolerating clear liquids and discharged. Full liquids, day 4 to 13. Pureed foods for a couple weeks, then going to soft foods, and then week 7 beyond, solid foods. But you really want to concentrate on a high-protein, low-carbohydrate, low-fat diet. Okay? Diet is very strict. The capacity of the food you can eat has changed very dramatically. So if people, after a lap sleeve, went out and they ate a Big Mac, you'd rupture your stomach. It's just the size of an egg. And physically, it can't expand that much. So your meal capacity is much smaller. Length of time to return to normal activities is typically about 2 weeks, although there are a lot of changes that occur. And your body will respond differently to alcohol. So particularly after gastric bypass, we know that after gastric bypass, patients are now turned into very cheap dates because alcohol is absorbed very rapidly. So one drink can be the equivalent of alcohol in your bloodstream of about 2 drinks. Okay? So you get very tipsy very quickly after gastric bypass. Setting yourself up for success. So the social support system is really important. It's really disheartening to see some of our patient families come in the night after surgery, the first postoperative day. They bring in the either McDonald's or the fried chicken with the French fries and the Cokes and everything else, and eat there right in front of the patient. And we also know that patients who undergo bariatric surgery, the rest of the family tend to lose some weight with the patient. Now, 80%, about 75 to 80% of our patients are women, and many of the women are preparing the meals and thereby selecting what things the kids or the husband might eat, and therefore the rest of the family tends to lose weight too. Set realistic goals, follow medical recommendations, high motivations, ask questions about expectations and participate, be empowered, because really it's not magic. The patients still go through a lot. You have to do the right choices and the right things. There's oftentimes a very difficult transition time, and it's lifelong. It's you have to do those things that are going to enable you to do well, but because you've changed biology, you're now able to much better diet and do those things to achieve success. Okay, are you a candidate? BMI of greater than 35 with comorbidities like diabetes, hypertension, sleep apnea, or greater than 40 without. Healthy enough to undergo a major operation. I've done this operation in patients that have previously undergone a heart transplant, liver transplants, all sorts of transplants, or patients that are about to undergo transplants, because if you're a dialysis patient, okay, have kidney failure, guess what? You cannot undergo kidney transplantation if you have a BMI greater than 40. There's no program in the United States that will transplant your kidney if you have a BMI greater than 40. Why? The results are awful. You're 3 to 4 times more likely to lose the kidney. You're 3 to 4 times more likely to die, okay? Because guess what? The transplant medications for immunosuppression are called steroids. The steroids cause your blood sugar to go out of whack, and guess what? The steroids cause you to gain more weight, okay? Meaning your diabetes goes out of control, you're now immunosuppressed, so you're at high risk for infection, diabetic complications. So there's not a program in the country that will do your kidney transplant if you have a BMI greater than 40. And most of them will not do it if you have a BMI greater than, say, like 35 or 32, okay? So I have done in the past a lot of patients that were about to undergo a transplant of many types so they could actually do better after their transplant. Failed attempts at medical weight loss. I've met 2 patients that came in and told me that they'd never been on a diet, would not do their surgery, okay? I don't know how you could be in America and never be on a diet, okay? Absence of drug and alcohol problems, no uncontrolled psychological conditions, consensus by our multidisciplinary team. In other words, everybody has a role to play, so if anybody on the team tells me that they have concerns about certain people, we try to address that, and we try to make sure that the patients are supported well. it's hard sometimes to predict who's going to do well and who's not. Some of the patients that I thought would not do well have done extraordinarily well. Then again, you get some surprises. Adolescents are particularly surprising. They will do some surprising things, but then again, they're some of my best patients. You have to understand surgery and the risk and be committed. Considerations about the right procedure: age, health risks, amount of weight to lose, lifestyle, eating behaviors, mutual decision between patient and surgeon, discuss with family and friends. A lot of times we'll have patients come to our support groups so they can talk to patients so they can really get a good idea about what things go on. We do a lot of things about trying to educate patients. We work a lot with our primary care physicians, consult with us. There are a lot of things that are contraindications. So I go over all these things and make a determination about what type of surgery is good for your particular situation. Verify benefits and obtain insurance authorization. That's usually the hardest thing. Counseling, preoperative testing, surgery, lifelong follow-up. We really try to follow our patients lifelong to try to get an idea of how they're doing and lifelong sort of care. Okay, so insurance, I'm not sure I'm going to go over this a whole lot, although they have very stringent insurance requirements, and I think that's important to know. The other thing that's important to know, the only operation in America that CMS or Medicare, that the federal government says has to be done in a center of excellence, is bariatric surgery. Anything else, they don't really care. If you're an MD and you decide to do an operation that's an operation, Medicare will pay for it, except bariatric surgery. Bariatric surgery, they limit it only to surgeons and to facilities that are certified by the American College of Surgeons as being a bariatric center of excellence. This has been true for about the last, I want to say, 6 years. It's the only operation. I suspect it will remain the only operation that has this requirement. Okay? So we're actually, as bariatric surgeons, we have more imposition of federal control and guidelines than any other surgical or medical practice. Okay, there's our Maston Clinic. And obesity prevention and treatment for obesity is really a journey. It's lifelong. Every day you wake up and make choices. So it's not a destination. It's not like magically you're transported to this nirvana and everything's hunky-dory for the rest of your life. So, any questions?
Yeah, after this surgery, if you have that, how often do you need that gallbladder surgery or surgery for excess skin? I mean, is this just the beginning of more surgery?
Okay. So the question is, how often is this just beginning for many more surgery? Do you have to have your gallbladder taken out? Do you have to have excess skin taken out? Do you have other things that you need to have done after you've undergone bariatric surgery? So, gallbladder. So, people who lose weight very rapidly are at high risk for developing gallstones. Okay? So, it used to be very common that people would develop gallstones after bariatric surgery. We have a medication that we give our patients, Actigol. It's a bile salt that dissolves gallstones, and if taken for the first 6 months after bariatric surgery, successfully prevents the occurrence of gallstones. So that really the risk of developing gallstones after bariatric surgery can be prevented should you take that medication. Now, what is the risk of excess skin? Okay, so here I will tell you that, number one, it depends upon who you chose to be your parents. Genetic heritage, how obese you are, okay? But it is very, very common to see patients losing tremendous amounts of weight. 100 pounds, 200 pounds. I've seen patients lose 200 pounds long term. And yes, that leaves a lot of excess skin. Now, typically, the insurance companies will pay for the excess skin in the abdomen because it hangs down. It oftentimes is painful. The skin around underneath the folds gets wet and macerated. You get fungal infections. The skin breaks down. It's a portal for infection, and it's a problem. So, yes, they will pay for removal of that skin, okay? The so-called bat wings that occur, unfortunately, the insurance companies generally say that they believe that that's cosmetic, and therefore they don't cover it. But remember, the bariatric surgery is meant as an improvement in your medical condition. We know from long-term studies, we have the Swedish obesity study, we have the Utah study, they all show the same thing. 15 years compared to a group of patients that did not undergo bariatric surgery, compared to a group of patients that underwent bariatric surgery 15 years later, the bariatric surgery patients have maintained weight loss. They have a decreased risk for cancer, for heart attack, for stroke. They are happier, healthier individuals, and they're much more likely to be alive. Okay? Every single study has shown it. We have head-to-head trials, intensive medical therapy for treatment of diabetes versus surgery for diabetes. Guess who wins? At 2 years, surgery has won every single trial. Okay? Not only do we treat the diabetes more effectively, they're off medications, they live longer, their diabetes is under better control, their lipids are better, their heart attack risk is much lower. So we do tremendous amounts of, I think, good for selected patients that fit these criteria as long as you do it in a bariatric center of excellence. But yes, patients routinely will undergo more surgery. But then again, they're alive to undergo more surgery. Any other questions?
I have one more. We love to go to the Y and exercise, but afterwards I am absolutely starving. I take food with me, banana, apple on the way home. What happened with those ghrelin? Is that good? I don't know if you said
Ghrelin.
Yeah, what happens to that when you exercise? We usually
I don't know.
3.5 hours or so to Y.
Really? Okay. So one of the things that may be occurring in your case is that it's not only ghrelin, but low blood sugar is a very strong stimulus to hunger. Okay? That's one of the major stimuluses to hunger and your brain to trigger you to eat. And it sounds like you are exercising and developing low blood sugar. Now, that I would have to think about this, and I'm sure there's some experts, and we might want to ask Tammy about that, Valerie, and maybe ask one of our. That's an excellent question. So, write down your name and email address, and I'll see if I can't research that a little bit. It might take me a little bit of time to figure out exactly how I should handle that, but that is also akin to what you need to do before running a marathon. okay? Because you're going to be exercising for 4, 5 hours or 6 hours, and some of your glycogen stores, glucose stores, are being taken up. And how do you maintain those stores when you're exercising to prevent that low blood sugar? So it's an interesting question. I can't answer you completely, but I can posit some theories. Okay, give me a question I can answer.
I think you might be able to answer this. How can you block the leptin, or is there any drug that you can have control the leptin?
Okay, so the question is, how can you block leptin or control leptin? Okay, so it's leptin deficiency that causes super obesity. And indeed, I guess it was discovered about 20 or 25 years ago, and we found a number of people that had extreme leptin deficiency. We still look for it in young kids. So usually if you're 5 years old or 6 years old and morbidly obese, the pediatricians are really thinking leptin deficiency. Okay. How do we control it? So far, you can give leptin because it's a leptin deficiency. If you give leptin to these patients, they will start eating normally and stop eating, okay? But it's a very rare... I have never seen a patient with leptin deficiency myself personally, okay? I have, however, this is a sad story. On Friday afternoon, about a year before I left Vanderbilt, I received a STAT emergency call from the pediatric intensive care unit at Vanderbilt for me to do a STAT bariatric consult. It was a 15-year-old boy who weighed about 400 pounds, was in the intensive care unit there in the pediatric ICU. He's diabetic, hypertensive, with heart failure from his morbid obesity, okay? He was on IV drips to maintain his blood pressure because he was in florid heart failure, on a ventilator, okay? And the pediatricians were anxious for me to operate to get this patient lose weight so they could get him off these drips and everything else because they saw it was going to kill him. So we worked with him, and I talked to the family, I talked to him, and we went through and we consulted for about 4 weeks. He remained in the intensive care unit for those entire 4 weeks, okay? We gradually got him to lose some weight. We were preparing him for operation and everything else. And then I received a call about 4 weeks after that initial emergency consultation. He had died. He had but honestly, young kids that weigh that much, they're developing hearts and everything else. His heart just failed, okay? So we're seeing it at increasing levels in our young children and things like that. We do look for leptin deficiency. We just don't see a lot of it, okay? But it's it makes you think, well, maybe if I ate more leptin, even if I had a semi-deficiency, maybe that would make me eat less. Or maybe if we could block ghrelin, if we had an anti-ghrelin, we'd just cure obesity, okay? But remember, I said there were 30 other drugs, okay? 30 other hormones that affect eating behavior, okay? So think about it. Surgery affects all those 30, okay? But if you have just block one those hormones, then the other 29 will go differently. Now, as opposed, we are going to cure cancer well before we cure obesity. Why? Because many cancers are just one genetic defect. So there are some cancers we can cure with a drug that respond to that one targeted molecule that's changed by that gene mutation. And we've got multiple examples where we have a miracle cancer drug. You give that miracle drug for that gene mutation, and the cancers just melt, okay? Obesity has got all these things that are changing, okay? So you knock out one, the other 29 are sure to take its place. And you would think that surgery is so powerful, and when patients start to lose weight, why don't we see patients continue to lose weight until they die? It doesn't happen. And in fact, we rarely get to 100% excess weight loss. These patients rarely get down to normal weight levels. Okay? It's a fascinating thing. Fascinating thing. But so my prediction is that we will cure cancer well before we cure obesity. So my job as a bariatric surgeon is actually probably much better than my job as a surgical oncologist. The other thing that's fascinating, we're now doing some studies to suggest that breast cancer should not be treated with surgery at all, that they're just doing chemotherapy and radiation for breast cancers, that mastectomy may not be done at all for certain types of breast cancer because some of our drugs are so powerful for it. So anyway, interesting thoughts. There's a question back there.
Exactly. I was just going to say I've been reading up and now single incision laparoscopic. Are y'all working towards that?
Okay. So, yeah, I used to do single incisions. It was a long incision. The single incision idea is that you do, instead, we do multiple incisions, put all these trocars and access the abdominal cavity. The single incision is an idea that you make just one single incision, usually around the belly button, hide it in the belly button, and then do all your surgery, and then you don't have any other scars, okay? I have not done a lot of single incision surgery. I've done some. Really, I'm not looking towards moving to that. We may look at it in the future, but right now we're doing laparoscopic surgery. It's got tremendous benefits, and we're just not moving to that.
I couldn't even buy my scars anymore. I looked for them the other day, and I cannot buy the scars from the laparoscopic. I don't see why you wouldn't go with that, so you can have all kinds of movement with robotic arms.
Well, that's sort of my thought, but... Question?
Someone has type 2 diabetes and has gastric bypass. How soon do you see changes in insulin sensitivity, maybe where they would no longer be insulin dependent?
Okay, so the question is, after laparoscopic gastric bypass, they have changes in diabetes. How soon do you see the changes in insulin resistance? Typically, we've done some studies in this. We can show pretty dramatic changes within 3 months. Many of our patients change in the hospital, okay? That is, before they were taking medications, after surgery, when they go home, they're no longer taking medications. They're oftentimes just monitoring their blood sugar. So the changes occur fairly rapidly. There's a lot of questions about what causes these rapid changes.
That's preceding a lot of weight loss.
It's preceding, so the changes that we see precede a lot of the weight loss. Now, one theory, one of my colleagues, Dr. Boomrod, believes is that the fact that you're eating a whole lot less calories. So if you decided, if you're a diabetic, and you ate only 800 calories per day, mainly protein and no sugar, that you would do the same. That your blood sugar would rapidly start to come down, okay? Just decrease calories, okay? And the problem with that is that most patients on an 800 calorie a day diet, it's just undoable. You get so ravenously hungry that you just can't do it beyond, 4 or 5 days.
That's a nutritional idea, but is there any idea there's maybe a change in actual metabolism that's causing?
Okay. So the question is there a change in metabolism? Well, there is a change in metabolism. So we know that bypassing the duodenum and stimulating the intestine with food does cause some dramatic changes in the intestinal hormones, many of which I didn't put up there. It's a complex. Surgery changes a lot of things in the whole GI tract physiology. And that's why that slide was so important, because it's about 1/100th of the complexity of the system that we're looking at, where we have all these changes and all these peptides and everything else that are occurring. And so the changes in the decreased blood sugar are not just the result of the decreased calories, but probably the result of this complex interplay of hormones and other things that is changed with surgery. It's a fascinating subject. We're doing a lot of research in it, and trying to understand it, and indeed, trying to determine if there, and many of us believe that there are a lot of pathologic changes that occur that precede morbid obesity, that patients with morbid obesity, if you look at their ghrelin levels don't fall as quickly or as much as do normal weight individuals. Okay? If you look at a normal individual, ghrelin levels fall if you eat a 1,000-calorie meal. They fall for hours and hours. In the morbidly obese, they only fall a little bit, and then they're right back up to where they were. It's like your thermostat doesn't respond to what you're putting into your engine. Okay? So they have abnormal control mechanisms that are geared in the gut. I've gone over. Okay, thank you all. You were great.